Jenny coming to you from Nowheresville, America, from her hillbilly state. How y'all doing? Just wanted to give you kind of my opinion that I think the best thing that the defense could have done was to call what they would call an infectious disease or infection control nurse. Every hospital has these, or if they don't, they should have it. Basically, they are the oh boy, they're tough. Absolutely tough, and have to maintain standards in order for these hospitals are nothing but incubators of contagion, have the worst of the worst pathogens, and we have to maintain sanitation in order to basically save lives. And again, hospitals are admitting very sick patients. Many of them come in with these pathogens, and unfortunately, with all the sewage and everything, it just stays in that hospital. And unfortunately, these things that you know, these five-finger things that are on the hands of every healthcare worker, unfortunately, are the things that usually end up passing on various things to, one patient to another. And just another FYI, if you ever want to go to the hospital, do what you can to get the hell out of there. Because the longer you stay, your chances of getting an MRSA, which is basically an antibiotic-resistant staph or a Pseudomonas, are just astronomically high. So you kind of want to stay out if you can, or get the hell out of Dodge if you can too. As soon as they say you're stable to discharge, go. So basically, first of all, what they should have, the biggest mistake they did was to let Michelle Warden go, period. And this is why I state that, because apparently she was the policy and procedure person who updated all the policies and procedures, put those in place. And I bet they're still in there, and I bet they haven't been updated. So what I would have done, gone in, let's just say I am an infectious control nurse, and let me tell you, I don't think I have the skill to be one, but we're just gonna pretend I am one. And if at any point, if there's ever an infectious disease nurse or infection control nurse that is watching my videos and wants to criticize me or say, no, you got this wrong, please do. I want you to date me. But I'm just giving you my best guess of what they would have done. First of all, if I was that, I would have gone straight in and looked at the policy and procedures that Michelle Warden wrote, and would have sit there and said at the bottom, were they revised? Because they got to be looked at or updated or revised every few years. And all you have to do is just say updated and revised. Second of all, I can guarantee you 90% of these would have said something to the thing like, when you change a dressing on something, how often do you change the dressing on it? How do you change the dressing on it? Very important, because remember, a lot of these babies had what? UVC lines in the umbilical cord, and guess where they're located? Near the diaper. So you got to maintain a certain cleanliness for that. Another thing is that many of these babies were what on? IVs. These bags, they're usually adult size or partially adult size, and these babies don't need much in the way of fluid. So these bags, if you want to use it till it's done, can hang there for a week or two. You don't want to do that. You want to change these bags every so often, every 1 to 2 days. Again, there should be a policy for that. And what is that bag connected to? It's got a tubing. Again, you only want that tubing hanging for so long. So again, there should be a policy and procedure. I think we changed our tubings. This is when I was an adult nurse way back in the Stone Age in the 80s and 90s. I think your bags were changed once a day, once every 24 hours if they were hanging more than 24 hours, and your tubings were every 2 days. Again, that was back in the Stone Age, and there would be more updated so far as research as to what that is. Again, and then how far down would you go to change the tubing? Would you go to the actual needle itself? Not change the needle, but just change the tubing. Again, there should be a policy and procedure in there. How long should this needle be in this hand? You don't want those in for very long. You may have to get on to the doctor to change that needle, and some nurses are skilled enough to insert those lines too. Those needles have to be changed every so often, in the dressing, of course, too. And those UVC lines. Now, we as nurses cannot, although Michelle Warden might have been might have, because she was an advanced practice nurse, might have been able to cannulate those umbilical lines, but we knew there were no advanced nurses in there, so it would have to be the trainees. Again, you only want to leave those lines in the umbilical cord for so long, because it's just encouraging. It's near the diaper. It's just encouraging stuff to go in. Just an FYI, my daughter who was a premature daughter who wasn't, admitted due to sepsis, they got that UVC line out by the next day and had a little peripheral line in her too, just to make sure, because they knew she was septic. They wanted to keep this thing, they wanted to keep everything just fine and dandy. There also would have been policy and procedures as to when to draw what they would call peak and troughs on some of these antibiotics, such as like a gentamicin and stuff, or a vancomycin. You have to draw certain levels, a peaks at a certain time and a trough at a certain time. There's 2 levels. There's a certain timing to that, because otherwise these antibiotics would blow out the kid's kidneys or his hearing, and you could have some major complications. Again, there would be a policy and procedure as to where do you put needles, bloody dressings, stool, poop, all that stuff just spreads. So how do you dispose of all this? What containers do you use? There are special biomedical hazard containers you have to use. Policies and procedures, and how do you clean an incubator? How often do you clean the incubator? When do you clean the incubator? There should be a policy and procedure as to how far away each incubator should be, because you don't want them to close. There should be a policy and procedure for if the baby has what they would call an upper respiratory or an airborne disease. If the baby, I don't think these neonates would have, I would imagine neonates could have measles, RSV. There's a lot of things that are airborne, okay? We learned a lot about airborne viruses during the time of the pandemic. So again, where do you isolate these babies, and how do you protect all the other babies? There would be policies and procedures as to, how often do you take a temperature on a baby? When do you do monitors things? There should be a policy and procedure as to how you clean. Well, what about all these special wires that you have to tape onto these babies? And you got to change those too, because everything can harbor and just land on it and just kind of grow on it too. There should be a policy and procedure that. There should be a policy and procedure as to when you have to insert something, you have to clean it with a certain antiseptic. There's 2 types of antiseptics you would use. One, you would never, ever use on certain premature babies, because their skin isn't thick enough. It would act as poison. So which antiseptic do you use? There would be a policy and procedure as to, there's different types of disinfectants, and disinfectants are the things you would clean the monitors, the incubators with. Well, if it's an incubator and it's a certain time, you only want a certain type of disinfectant, because you don't want to poison the baby, obviously, and some of these are pretty strong with these bleach. You might be able to use that certain type of disinfectant if the baby wouldn't be anywhere near, or you may have to use that disinfectant, and there might be a way you would just in effect kind of remove it. Again, there would be policies and procedures for that too. There would be a policy and procedure how you would open a sterile package, per se. There is a certain way that you have to maintain what they call a sterile field. And that's going to come from someone who's extremely important. And someone made a comment on this quite a while ago about probably one of the most important physicians that has ever come out of the United Kingdom, if not the world. His name is Dr. Lister, and I will put his history in that, and I will definitely put that in the description for you to read. There's Florence Nightingale, who cleaned up things, and then there's Dr. Lister, who basically, he's the one that did the concept of antisepsis so far as operations and stuff like that. And it's because of him started all the techniques, again, how we would how we would insert a line at the cot, at the thing. You just don't insert an IV in a kid. You have, or an umbilical line or anything like that. You have to maintain a certain sterile field, as if to that area you would, it's like you're in an operating room, okay? Certain techniques. Again, I want to see the policy and procedure books. Now, to understand various things, I'm going to give you an example. If we, as an adult, when we ever had an infected patient, what we would do is obviously we would put them in an isolation room, all right? And then on the outside of that room, we have a little card. Now, we're not going to put down what the bug is that patient has for privacy reasons, but we're going to put the type of isolation you would have to do. First of all, to protect yourself, because you don't want the healthcare worker to catch that bug, but we also don't want that healthcare worker to spread that bug to that patient down the hall. So it would say something like a droplet precautions, and that tells me there's something airborne. If it's COVID, you got to wear an N95 mask. There's certain other things that would just be a regular surgical mask. Again, on that thing will tell you if you need a regular mask or an N95 mask. It also will tell you if you need to what we would call gown and glove. It would not be a sterile gown or a sterile glove. It would just be a protected glove too. It always will tell you to wash your hands upon entering and upon leaving too. And also you just don't dispose of all this stuff just in the regular trash. There's a special biohazard. Usually it's a red bag that you're going to throw everything into. And they can't just throw this out with the regular trash. They have to incinerate it, okay? Hospital waste. Again, once that patient would leave that room, you just don't let another patient in. You have to disinfect it, and you have to disinfect it there's multiple types of disinfectant. It isn't just bleach. There could be other things you could use. And again, this isn't stuff that you would buy off. I could go to the store and buy off of this. This is what we would call hospital grade. And there's also a hydrogen peroxide ones and other based ones too. Mainly mostly, many of them are usually kind of either a bleach or a hydrogen peroxide kind of base. But again, they're hospital grade too. Other isolations would be, let's just say you have something, an intestinal bug called C. diff. No, you wouldn't have to wear a mask, but you'd have to, again, you're going to be very, very careful with whatever if you would have to collect a stool sample from them to see if they are still contagious with that house bug too. There's a special procedure you have to do in order to, obviously you have the container, but you got to put the container in something that would protect everyone, as you're carrying the sample down to the lab, everyone. So it's, you're protecting everyone in that bag. There's a certain way you can do that too. Again, there's what they would call bloodborne pathogens and everything like that. Again, I'm kind of losing my train of thought here. Also, there's certain things that a hospital always has to do. Horizontal cleaning. Any horizontal surface, you can just assume it's infected in a hospital. You have one infected patient on that floor. Again, the nurse wearing a gown and a glove, that doesn't mean your hands aren't going to get dirty. This is not a guarantee wearing that glove that you may not somehow get contamination on there. Once you take that gown off and that glove off, you have to wash your hands too. Again, it's very important. We all, there's computers all over the hospital. Well, we got to clean those keyboards frequently. Again, there's always a chair. Everyone sits down in a chair. Well, if more than one person is going to touch that chair that's out in that nursing station, that chair has to be frequently cleaned. The floors, probably the filthiest place on the thing. They should be constantly mopping those floors with hospital grade disinfectant. I don't care where it is. And the hallways are constantly having to be mopped. Constantly. Again, if you can remember, I did a thing about how the unit itself, how the floors, there was just too much traffic And again, that's filthy. Your shoes are filthy. Everything is filthy. Again, there's should be a policy and procedure, like when you're doing a procedure, such as when they are inserting a line into something, they have to know, they have to put these sterile gloves on specially. They have to put the gown on specially. They have to, they can't lean over what we would call the sterile field. Again, something could drop, my hair could drop into the sterile field that has dirt on it too. So you have to be careful how only your sterile hand can go over that, whatever that tray is of instruments that you would need for that. And again, if you usually have someone, if you're doing a sterile technique, again, inserting a line, you want someone who is sterile, gowned and gloved up in that, inserting that line, and you want someone what we would call dirty. Oh no, I'm out of needles or out of syringes, go get me one. She would run and get it, or he, and then there's a certain way that they have to, literally, you can't lean over and put it in, you have to throw it in. So you can't lean over that sterile field. And again, that's why it's extremely important that you match the level of the baby to the number of nurses on the unit. Certain babies have to have 1-to-1, one nurse to one baby, certain level babies, you could do a 2. You could have 2 babies to 1 nurse. Very, very important. And how we level it again is, all the monitors, all the tubes, all the oxygen and stuff like that. And the reason that is important is that the first thing that goes, and I am guilty of that too, is when you're in a hurry, when there's an emergency situation, or you're just busy, I hate to say it, but infection control is the first thing that always goes in a hospital. Again, also, if I'm at a nurse, if I'm at that correct acuity, I have that correct number of babies I'm going to have, I'm going to be able to help that physician maintain that sterility in whatever procedure he or she is doing. That second pair of hands, I could be that dirty person that would run and get you whatever you would need. If you would have to insert, let's just say you would have to insert a tube down their throat, you would use an instrument called a laryngoscope, which is a metal non-sterile thing, put that down, but then you're going to have to you put a tube where you got to put that instrument down. I got to make sure I grab that instrument from you, but you don't put that on that crib, because that crib is, even though technically you're changing the sheets and everything like that, you're still changing diapers in a crib, in an incubator, in a cot. And even though you're changing it real well and there's no visible poo, doesn't mean there's not bacteria in there too. Again, there just would be a multitude of policy and procedures I would check. And again, if you didn't maintain those policies and procedure, or prove to me that you had those standards and you had tight, and I mean tight, infection control things, that would be doubt. That unit didn't have a hand washing station prior to entering that unit. That alone, that's to me is a doubt. Again, those I would say, well, why are they doing rounds on the pediatric ward prior to coming into the neonatal ward? Who is the most immunocompromised? It would be those babies. Okay, are you maintaining? Are you cleaning everyone? All these phones on the thing. Everyone, grabs a phone. The phone's on the desk. Are you cleaning those phones? Are you cleaning your individual phone? Are you keeping the parents? The parents can be just as dirty and can spread just as much germs as the nurses. What's your policy and procedure to maintain cleanliness with the visitors? All that. It's just a multitude of things. Again, all these little tapes that they'd have to put little masks on the baby and tape. Are you cleaning the masks? What are you doing with the mask? Again, all this oxygen stuff that they have to, little nasal things, or even the ventilators, the CPAP masks, you don't put dry oxygen into anyone. It has to be humidified. So there's all this humidity, your humidified air. Well, what loves moisture? Pseudomonas. That is one of the major factors in contamination of Pseudomonas. A lot of times it just loves the respiratory equipment. What's your policy and procedure? These all these tubes, all these things, those tubes have to be changed frequently. What are you doing with that? Are you getting again this tape? Okay, you're putting tape on these little babies, and their skin is beyond. It's even worse than paper thin. Well, you could be getting little micro abrasions, micro scrape, or even just ripping the skin off. Well, the skin is your major barrier to infection. You could just be giving them a skin infection. What is your policy and procedure for oral care for these babies? Again, oral care. You know, mouths are a huge harbinger of bacteria. Mouths are filthy. Are you doing that? What is your policy and procedure so far as how often are you supposed to bathe the babies? Are you supposed to bathe the babies? What type of soap are you using on these babies too? Are you irritating their skin? But you also want to make sure it's a strong, I don't want to say it, disinfectant, antiseptic kind of a soap too, but what soap are you using on these babies to wash them? Or should you be bathing them? You know, there should be a policy and procedure as how often should they be bathed. Where are you getting your water from? Again, a lot of these babies, they'd have to use water in order, various medications you would give. You'd have to put down the tube, and then water. You always have to follow it with some water too. Well, where are you getting your water from? I hope you're not getting it from the water taps that's with Pseudomonas. Oh, also again, suctioning a baby. A lot of these, you have a tube down your throat. You have a lot of mucus. Are you suctioning? How often are you changing that suction catheter? The container that's getting that mucus, are you changing that? There are certain suctions that you're able to maintain. It's like a contained suction to do that too. Are you cheaping out and not using the contained suction catheters? Are you using the correct ones that is contained? It's not, again, that's going to maintain as a cleanliness at all. Do it. Also, a lot of times you have to give those babies IV medications too. So again, you're sticking something into an IV line. Well, what are you using as an antiseptic to put that in? Or are you using there's a certain closed container way to do it that maintains sepsis too. How often are you checking in on your expiration dates on all your things? Who checks your expiration dates on, even though you have on your trays and all your equipment too? The trays that would have, like, let's just say I would have to, a baby would have to have a lumbar puncture, a spinal tap. There would be a sterile tray with all the sterile instruments, and you have your tray in there. Well, it only stays sterile for so long. There should be an expiration date on that too. And also all your individuals, not all, but most of your syringes are contained in a sterile package. It has a little expiration date on here. Are you checking your expiration date too? Oh, all your medications a lot of your medications are in the refrigerator. Are you disinfecting the inside of the refrigerator? Are you maintaining a certain temperature in the refrigerator too? Because if you don't have a certain temperature, you're just going to grow pathogens. Are you cleaning out the filters? Who's checking the machines? Who's checking the machines to make sure that their filters are cleaned on there? Who's cleaning the machines? All these monitors and stuff, those all have to be cleaned. All those tubings have to be cleaned. Anything, and those knobs, there's multiple hands that are touching those little knobs. Oh, the doorknobs too. Again, if you remember, I was saying on the tour of the unit, there was too many doors and too many knobs. We all touch a knob. Well, how clean is that hand that touched that knob before I touched that knob doing it? Again, breast milk was being stored on the unit. Who's checking to make sure the breast milk hasn't expired? Who's making sure? Who's teaching the family, the mother, when she pumps breast milk, to do it in the most aseptic manner? So there is massive multitudes of particular things that you have to do. Oh, fingernail, you can't have really fingernail polish or gel, and you have to be, nothing from the elbows down. Who's checking around for that? Do you have what we had? In my, and again, before I would enter the neonatal unit, I always had a lookout for one of these infectious control nurses. I gave her the nickname. Of course, I never told anyone or told her. I gave her I knew what she looked like. She was the stalker. Do you have stalkers? And I'm glad there was a stalker, even though, you know, you know what? Every hospital needs to have those stalker nurses, and they are definitely wonderful. Oh, again, another thing, you should be periodically going around and just randomly culturing monitors and culturing things just to see as a surveillance type of thing. How are you making sure there's no pathogens in that room? Just, you just randomly culture things and just to see. Another huge thing is that I noticed in one of the unindicted babies, this baby who had a positive blood culture of group-based strep, that I am confident, I would bet $1 million if I was a betting woman that was what we would call a line contamination, meaning that pathogen got in one of the IVs, well, probably one of the main lines in that baby. And your hospital has to have a zero tolerance policy on all line infections, meaning if one shows up, that is a serious type of incident. That is massive. You have to do all the deep dives anytime any of that ever happens and look in to see how that occurred. Again, on your, how clean are when you're sending, if a baby needs a chest x-ray and they're bringing that x-ray machine in, well, are they cleaning that x-ray machine? Because we don't know where that machine was. It could have been on an adult ward. It could have been in an isolation room. Or are they cleaning that machine before they enter the neonatal unit? And are they cleaning that machine as they leave? How clean are the hands of that technician that's doing it too? There's multiple people coming in. There's technicians that are bringing in, pharmacies bringing in their medication. This person's running in. Someone's coming in with something from the blood bank. This, that. And again, you'd have to prove to me that you were maintaining on the level of what would Florence Nightingale tolerate? I got a feeling if she knew that she's right now spinning in her grave, knowing about the filth in that hospital. That's just disgusting. Also, again, and it was a well-known fact that anytime you have an older building, you're going to have kind of what we would call in plumbing dead ends, meaning there's places where water just kind of sits for a while. You're just asking for Pseudomonas to come. Newer and improved things wouldn't have those kind of dead ends. There's a certain way that water has to flow in a hospital to make sure that nothing stays stagnant. And because Pseudomonas just loves hospital water or anything moist, Again, how is your ventilation system? How's your air? Because there's a lot of airborne thing. There was RSV cases in that unit. Well, again, how was the ventilation system? Are you taking that RSV stuff, which is just in the air, and all the other airborne pathogens? Are you just spreading it out there like it's, a fan? How stagnant is the air in there too? Are you ventilating a way that you're ventilating it out into the outside and not ventilating it out into the hallway too? You're bringing good fresh air in that's not infected. That air, whatever the air that's coming into that room, no matter what the room is, that good clean air. Oh, who's cleaning the filters, the air filters? Engineering, are they doing a good job? Because you can't open a window in these hospitals. Well, are they just like I have to clean the air filter in my furnace and air conditioner? Are they doing that too? Again, a lot of these, and it's happening again also in America too, where the housekeeper, the plumber, all those ancillary wonderful departments that kept that hospital clean, that kept pride in that hospital. They were employed by that hospital. You were part of that family. You worked together. Well, now, in order to save money, that housekeeping department could be, that's farmed out to that private company. That plumber might be farmed out to that company. Whoever's doing the air conditioning and the heating system, it's to a different private company. There's too much privatization going on in America, and I understand it's going on in the United Kingdom. Again, I encourage you to watch that video that I'll have in the description on Joseph Lister. And just another side note, America owes a lot to Scotland. I understand he wasn't Scottish per se. I think he was born in Britain, but I think he then went over to Scotland and was associated with one of the Scottish hospitals. We got our stuff together when it came to nursing. Before we had our stuff together when it came to our medical establishment. And the reason we did is that during the Civil War, both sides, both the North and the South, wrote to Florence Nightingale said, help. What do we need to do to, for the nursing, since she had such wonderful experience in the Crimean War. And she wrote back, didn't matter what side you were on. All she cared about is that you were taking care of a soldier. And then what she did, we would send people over to England, or she would send people from England over here. And that's how, when we established our nursing schools and stuff like that, it was the Nightingale method that did it. And it took a long time for the medical establishment to then take on the better. They thought they were, again, getting a medical degree was just, you send it a few lectures and paid a fee, and you got a certificate. The Civil War taught there was too many soldiers died from infectious and disease and poor care. And after that, again, they needed to realize they needed to get their stuff together when it came to medical education. And one of the main things is that they did, they borrowed the method from Scotland. Scotland had absolutely premier, incredible hospitals, incredible, I guess, policies and procedures and a lot of our medical schools were based on, I guess, I don't know if you would call it the Scottish method or whatever Scotland did. So we own a lot to Scotland. So we owe a lot to Florence Nightingale for nursing, but we owe a lot to Scotland so far as really, really getting our stuff together so far as medicine. And Dr. Lister had a lot to do with it, and just an incredible and wonderful man. So again, we owe as much to him as we do to Florence Nightingale, that we are healthy. And the problem is that we are not. We need to go back to them. We need to go back to their ethos, their strength, everything that they put out. We need to relearn their methods. We need to. I wish we could bring them back from the dead, and I wish we would have them go through all American hospitals and all the NHS hospitals too, and just clean everything up. But you take care. Bye-bye.